This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
It's actually very daunting following two professors, and even more daunting talking to a room full of real clinicians, because at my last hospital, palliative care doctors were called fluffy hand-holding do-gooders. So I've got no qualifications to be here. So this is a talk Daryl and I prepared, and okay, great. And I'm going to start with a case study. Mary's 88. She was admitted with an exacerbation of heart failure and COPD, and she had a MET called for some hypoxia and hypotension. The palliative care registrar attended because our palliative care registrar attends a certain number of MET calls across the hospital. The medical registrar told him very clearly that he wasn't required at this MET call, but he decided to stay and offer comfort to the husband because no one else was doing that. The next day he was called by a rather sheepish medical registrar to say that the husband had requested a palliative care consultation, and comfort care was implemented and the patient died 36 hours later. Oops. So why do we need to plan for death? Well, a lot of the speakers have already covered that, but really indecision greatly increases the odds that one will get a very bad death. And if we want to look at it from the perspective of the patient, we need to say, well, we need to think about why the patient will want to extend their life. What do they want to use more life for? What will it enable me still to do or enjoy? And what risks do I undertake if I choose to live on? Because one of the problems I see in the hospital is that the doctors stand at the end of the bed and they can say, yep, I can cure this pneumonia, I can remove this appendix, I can do whatever it is you want me to do, without looking at what the patient's life is going to look like at the end of the admission. So Austin Health is a tertiary teaching hospital in Melbourne. We've got 780 beds across 3 campuses, and the MESH, as you've heard, was introduced in 2000. We are one of the completely unfunded programs that have been described. Last year there were 2,500 MET calls across the hospital, and a third of those were end-of-life calls. And many of them are also multiple MET calls. And the question that's been raised for several years is that when is a MET deterioration due to a reversible condition versus due to the patient actually dying? Can we predict MET calls? Well, we've heard from our speakers today that probably there's a third of them that we can't. There are numerous prognostic tools for general and specific illnesses that you can apply on admission. There are general factors including multiple recent admissions and also functional decline, as Ken alluded to. The UK uses the gold standards framework, and the surprise question is talked about widely. My only concern with that is you need to have a reasonable amount of clinical experience to be able to judge whether it's going to be a surprise or not, which doesn't apply to most of the residents in our hospital. And there are general and specific indicators of decline. And then we come back to the question of multiple MET calls on one patient. Now, you've heard about all these studies, they've been presented this morning, but you can see that 20 to 30% of all MET calls are repeat calls. And although the study by Kalsavakis showed that a big chunk of them were surgical patients, what is clear that if someone has multiple MET calls, they have a longer hospital stay and an increased risk of dying. When it is possible not to save a life, then I've learnt to save a death, to help a patient preserve comfort and dignity, to help a family understand the inevitability of death and how to move forward in the process of bereavement. And I think this is one of the key roles that we senior doctors should have. And this was written by an intensivist who was surprised that she got more letters thanking her for the care of patients who died than for those whose lives she'd actually saved. So at the Austin we realised we need a hospital-wide approach to reducing the number of end-of-life care MET calls, and I'm just going to talk about 3 initiatives we've got at the hospital. These aren't rocket science, and many of you will have one or all of these at your hospitals, but this is what's working for us. We set up the End-of-Life Care Committee nearly 3 years ago now, as it's a subcommittee of our Deteriorating Patient Committee, as we realised that we needed to improve the care of patients who are actually dying and not going to improve from the MET call. And we've got a really broad membership across the hospital, and we have 2 to 4 people a month asking to join this committee. And we developed a model for end-of-life care at Austin Health. And basically what we did was outline what are all the factors that will determine whether a patient has a good death in our hospital. There are external factors such as government policies, quality standards, in particular the End-of-Life Care Consensus Statement, and peak body statements. There are hospital factors such as the culture, clinical leadership, the hospitals we've got there and the education we provide, and then there are ward-based factors. And we've now got work going on in all of these areas to improve end-of-life care at Austin. One of the initiatives that was driven largely by lobbying from intensive care and the deteriorating patient committee was actually getting a palliative care registrar onto the wards. We know that junior medical staff are not confident in their end-of-life care discussions, and we do provide didactic teaching, but we also know that that will only give them about 10 to 20% of the skills and confidence they need. And what we really needed was modelling on the ground by an experienced registrar. Now, as you've heard the other speakers say, the intensive care team is doing that. They're teaching with every MET that you have, but we wanted to get someone in earlier, and so our registrars attend medical meetings and help guide the registrars in the discussions. So the palliative care consult registrar position was created at the beginning of last year, and in the first 6 months of that rotation we were getting about 10 to 20 referrals a month. We're now getting more than, or the registrar is now getting more than 45 referrals a month, an increasing amount from the doctors themselves. The other main project we've done is the Clear Decision program. So it's consultant-led leadership in end-of-life care, advanced care planning and treatment decisions. And Sarah is a palliative care consultant who's a project officer, and Daryl, Simon and I are the leads of the project. And as you can see, we've got intensive care, emergency and palliative care working together to improve this. So, as we all know, ward staff have difficulties identifying the possibility of dying. They're not confident or even competent to hold the discussions, and they're not confident about making decisions about goals of care. And so they look to their seniors to guide the discussions and the decisions. The problem is that a lot of our senior medical staff either aren't on the ward or they're not making that call, which means everything's left in limbo. The consumers are saying, we don't want babies telling us that we and our family are going to die. And so the senior medical staff executive identified that we needed to provide a strong direction and clinical leadership. So this project started in August 2013. We've got the CEO as our executive sponsor and a steering committee consisting of surgeons, physicians, advanced care planning, spinal and emergency staff. So it's quite broad. The idea of the project was to identify clinical champions in each area who would highlight the need for clinical leadership and decision making, and most importantly only offer beneficial care. So as Ken said, don't offer them a full smorgasbord of what would you like or what wouldn't you like, but tell them what's realistic and possible. And we wanted the senior medical staff to teach their teams how to make end-of-life care and advanced care planning a routine part of daily care. And communication, as has already been highlighted, is a critical part of this. But rather than just roll out a program that told everyone what they had to do, a big component of this program was that we aim to tailor initiatives in each area according to the culture of the staff and the ward of that area. So rather than saying, here's program X, you will implement it, we actually went to different areas and said, what do you need to do in your area to improve end-of-life care? And a big chunk of what we did was actually build bridges from each different unit to existing resources within the hospital. So out of our goals, we had to identify clinical champions in each area, and what we've got is we've got over 40 clinical leaders who've been identified across the hospital. We had several targeted projects. The advanced heart failure one I think is particularly impressive because I gave a talk to them at the beginning of all of this, and it was like a light globe went over their head because they realised that they were doing this really well in their private practice, but because of the nature of public practice where the doctors are changing so frequently, no one had corporate knowledge of the patient and was kind of looking at the whole patient. So cardiology went on to form their own end-of-life care committee, and as of 3 weeks ago they've asked the palliative care staff to attend each of their weekly multidisciplinary meetings, and we're now getting 2 to 3 referrals from cardiology a week through that process. We've done an end-stage liver failure project, and also oncology and ICU have met. We've held 2 senior medical staff end-of-life care forums to talk about what the issues are in the hospital and how we can improve them. We've updated clinical resources. So on our electronic discharge summary, we've created a space for the doctors to provide a handover to the GPs about any advanced care planning discussions that have been held. We have electronic alert system for resuscitation plan, but none of the doctors knew how to use it, so we've had a cheat sheet designed so that they can then know how to do this. We've updated or implemented new policies so that there is guidance for the doctors on how to provide symptom management at end-of-life care, and we're working on a hub. We've written it, but it's just not uploaded on our intranet, a whole list of resources for doctors to link into. Given that communication underpins this work, we've held several communication workshops, including having an external speaker come in to talk to 45 senior medical staff. We've run several registrar communication workshops and also sessions for our junior medical staff. This year we got funding again for another 6 months of work, and our main aims are to consolidate the change that we've already seen last year's project and to embed the processes into the Austin framework. We're continuing the communication skills training as it's been highly regarded by those who've attended. This year's Senior Medical Staff Forum, we had senior nurses invited to the first one and had a really open discussion about what some of the barriers are for nurses to be allowed to express concern about the plans or lack of decision making. And later in the year we're going to have a session with Allied Health and our senior registrars for the same reason. We're looking at rolling out the Care of the Dying observation chart that's been implemented in New South Wales. And we've also redesigned our resuscitation form, and we'll be calling it Goals of Care form. And we're doing that in process with all our advanced care planning documents so that the same language is used again across all of the processes. And with the education resources, the communication workshop is going to be developed as in a written form so that anyone can actually deliver that, and it won't be dependent on our project officer to deliver it. It's really important that we recognise that death is a natural part of life. The benefits of our project, I'm talking to the converted, so I don't need to tell you, but the bottom line is it's appropriate patient care, it's high quality patient care, and it's respecting patients' wishes. And we're not providing non-beneficial or even harmful care. We know that a poor death is a big issue for not just patients and carers, but the staff themselves find it distressing. It's an optimal reallocation of resources and also the use of our beds so that the patient's receiving the right care in the right place at the right time. And for many of these patients, that care will be at home rather than in the hospital. Has it worked? Well, we're biased. We think it is, and there seems to be more energy in the hospital about this, and I think the fact that we are getting more and more people asking to come on the committee is a sign in itself that it's doing good work. This is the referrals and admissions to the palliative care unit over the last 5 years. 2013, the first red line is when the project was started, and you can see there's been a significant increase in admissions to the palliative care unit in this time, and we've actually had to increase beds to allow for it. And Jerry Seinfeld, I think, should have the last word.